And then there's a bunch of different spinal cord syndromes that you need to be aware of: anterior cord syndrome, central cord syndrome, and Brown-Séquard syndrome. And we'll talk a little bit about each of them. In terms of trauma, anterior cord syndrome is very rare, almost never seen. It's most common in discitis, where you get infarction of the anterior spinal artery and you have no motor sensory function below the level of injury, but you have retained dorsal column function. Unusual in trauma. Central cord syndrome, like I said, is super common, probably the most common spinal cord injury that we see. And we'll talk specifically about how those patients present in a second. And then Brown-Séquard syndrome is more common in penetrating trauma like knife injuries or gunshot wounds, where you get a hemisection of the cord. You'll have ipsilateral motor paralysis and contralateral loss of pinprick. And that's a Brown-Séquard syndrome, ipsilateral loss of dorsal column function. So ipsilateral loss of proprioception. And so we've talked about all of this. Anterior spinal cord syndrome is rare. Acute traumatic syndrome, spinal cord syndrome, super common. And what defines it is basically patients who present with severe hand weakness, greater than arm weakness or leg weakness. So they're paralyzed in their hands, but their leg power is pretty normal. It's pretty classic. Elderly patients, hyperextension injury with imbuckling of ligamentum flavum in an area of pre-existing stenosis. The sensory loss is typically incomplete, and patients tend to improve over time. So this picture is probably 65 years old. It was drawn by Netter, and almost everything in it is correct except for the bottom left figure. But again, older patient, hyperextension of the neck, has inbuckling of the ligamentum flavum, compression of the cord, weak hands, and strong legs. And the reason why it was called central cord syndrome, it was always thought because there's an area of central damage to the cord, that the corticospinal tract is somatotopically organized, and you're preferentially picking off the upper limb fibers while the lower limb fibers remain intact. And if you look at any textbook, Gray's Anatomy, Greenberg, the neurology textbooks, Harrison's internal medicine, all of them have this figure, which always drove me crazy. And I'll tell you why. So there's a bunch of syndromes in addition to central cord syndrome. Bell's cruciate paralysis is basically central cord syndrome with a patient who has an upper cervical cord injury. And it was described by Bell, but they present similarly with weak hands, strong legs. And it was also felt that the reason for this differential, presentation of arms and legs is that there was a decussation difference in the arm and leg fibers at the cervical medullary junction. We know that the corticospinal tract decussates at the medullary pyramids, and he hypothesized based on some old literature that they decussated at different levels, that you picked off the arm fibers, and that's why you got weak legs. So this leads to this here, and it's very timely because we just published this literally this weekend. It came out in Journal Neurosurgery as the front cover, and it's basically entitled A Critical Reappraisal of Corticospinal Tract Somatotopy. And the gist of the paper is, and you'd have to read the paper to really sort of understand the reasons behind it, and we don't have enough time to go into the details, but it basically says that, these pictures from Gray's Anatomy, Greenberg, and from Adams and Victor, which is the principal neurology text, is incorrect. There is no somatotopic organization in the corticospinal tract, even though there is for the spinothalamic and the dorsal columns, and that really the basis for the problems with hand function is that the corticospinal tract, which is uniquely human, and we need, there's major evolutionary differences in the corticospinal tract between a rat and a human, is predominantly important for hand function. And if you get a diffuse injury to the corticospinal tract, it will be manifest with weak hands. So that's basically the gist of the paper. And this figure is actually on the front cover of the Journal of Neurosurgery April issue. So the Brown-Séquard syndrome we've already talked about. There's also Conus medullaris syndrome, which is involving the conus of the spinal cord, where you get prominent autonomic dysfunction because of injury to the conus, so loss of bowel bladder dysfunction, and usually a combination of upper and lower motor neuron findings. That's a conus syndrome, as opposed to a cauda equina syndrome, which is typically below L1, L2, and it's a pure peripheral nerve injury, so no hyperreflexia, only hyporeflexia, tends to be asymmetric, tends to have prominent autonomic dysfunction, and has a slightly better potential for recovery than a Conus syndrome.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.